directed towards Dr. Ando. What kind of success have you found with Augustudo for Mage syndrome, tardive dyskinesia, and dystonia?
Okay, so Austedo is a new version of tetrabenazine. It's kind of if you're a pharmacology wonk, it's a really cool story because they took this old drug and they added a few neutrons to it, and it changes the way it's metabolized. So it's a longer acting version of tetrabenazine. And as an aside, it added 6 neutrons and it sold for $3.2 billion. So I think it's the most expensive thing ever purchased on the planet. But it's a medicine, one of those that inhibit the release of dopamine, okay, that we talked about. Now those are sort of two different things. Tardive dyskinesia is something caused by a reaction to drugs that block dopamine receptors, and it's treated by medicines that inhibit the release of dopamine. It's extremely effective for tardive dyskinesia, okay? Now, regular dystonia, cranial dystonia, and Mage syndrome is an older term for cranial dystonia. We tend to call it cranial dystonia now, which means dystonia of the whole face. You know, I think it has some modest benefit, as we showed, but it's much less effective for idiopathic dystonia like blepharospasm or cranial dystonia than it is for tardive dyskinesia, where it's just extremely effective.
I'm just going to say we have like an amazing number of questions here, so I'm not sure we're going to be able to get through all of them. But
I'll keep those shorter then if you go forward.
This one I think is for Dr. Guillet. What are some of the long-term effects of DBS, deep brain stimulation? Anything that we need to be concerned about, or that you're concerned about, or that have been shown sort of in the long run?
So for the long run, there have been some reports that the efficacy of the deep brain stimulation does decrease over time, but I don't really have like a good statistic to give you about what percentage of patients do experience this.
Okay. Let's see. I guess I'll open this up to the whole panel. What is the percentage of patients you see with a similar family history? I guess that goes to family history of blepharospasm.
It's not, yeah. Focal dystonia is overall, and there's been scientific studies on focal dystonia, meaning blepharospasm, cervical dystonia individually. Maybe 1 out of 5 people will have a family history. My personal anecdotal experience is that maybe be a little bit less in blepharospasm.
So far, I haven't had anybody with family with the. So far, my patients, I haven't been able to identify somebody who has a family member, but based on the studies, this can range from 5% to 25%. So 1 out of 5, or even less than that.
And some of the genes that were discussed earlier, they tend not to. Those genes tend not to have just isolated blepharospasm. Most of the genes as she discussed tend to be more general dystonia.
Dr. Rashana, you mentioned that smoking and drinking coffee, and you said you don't recommend patients smoke, but do you recommend patients drink coffee or increase their coffee intake? Can you comment about that?
I always counsel about stop smoking, no matter what. I do not particularly ask them to drink more coffee or not. It's just up to them. I don't think it will worsen the disease. I'm not sure if it has that protective effect, but this is what has been described in epidemiological studies, looking at what patients with blepharospasms do and see if the ones who have this coffee consumption intake probably doesn't have it compared to those who do. So I do not counsel one way or the other, but I do counsel about smoking cessation all the time.
I get this question sometimes as well. Acupuncture. Is acupuncture considered an option for blepharospasm?
Yes.
It was on my list, okay, as, you know, something that I think actually does have very good scientific data for pain. I don't think there's good scientific data for acupuncture, dystonia, or involuntary movements, but obviously it's a fairly benign thing to try, and it's thought to have some general relaxation properties to it. That's about what I could say.
Dr. Guillet, the question is, why frame-based targeting when it seems like you can be more precise with direct targeting with MRI? Can you talk about what's your decision-making in terms of choosing one technique versus the other?
So that's a great question, and that's been debated in our DBS circle, you know, for quite a few years now, since there has been the advent of a sleep DBS with direct targeting. And the reason for doing the argument for indirect targeting is that even if you do get a good target and you're able to see the nucleus and you target well, sometimes function does not follow structure. So it would be nice to do the microelectrode recording and confirm that even if you are in the correct spot, that would provide the best benefit for the patient. And then that way you have two different confirmatory measures, both anatomical as well as function.
And there's a follow-up question. Does blepharospasm meet criteria for DBS when we're talking about insurance coverage?
Yeah. It just depends what you write down in the code book. Even dystonia, for the adjusters, dystonia isn't covered, and you kind of have to fudge it a little bit to get insurance coverage.
Dr. Rashani, when we talk about imaging and functional imaging, is there a role for functional imaging in guiding therapy, or is it pretty much just research and diagnostics right now?
So far, what I have been able to find in literature is this only for research, not so much. You don't do this kind of imaging every patient that has blepharospasms, to the best of my knowledge. So it's mostly for research. And we still do not understand whether these proceeds or cause, does this cause the disease or is a consequence of it? So it's basically for description at this point. These are the changes we find in patients with different type of dystonia. But as you could see, the data is very mixed, or the results are very mixed. In some of them, there's increase in gray matter volume, in some others are decreased. So, no. Okay. The answer will be no.
Do you think in the future that's a possibility?
Yes, probably when you understand a little bit more of the pathophysiology, you understand better the pathophysiology, maybe there will be a role for that.
I think this is a question that might be directed towards the entire panel here. What about apraxia of lid opening? What kind of studies have been done on this in terms of the various treatments, whether they're medical or surgical, deep brain stimulation, or any insight there?
So apraxia of eyelid opening is a little bit of a controversial term. It's most associated with other neurodegenerative diseases, Parkinsonian type features, progressive supranuclear palsy especially. And you don't, in apraxia of eyelid opening, you don't see the forceful contraction that you see in blepharospasm. Now that being said, if you actually stick an EMG needle in there, there is co-contraction of muscles a little bit. So like I said, it's a little bit of a debate if it's a completely different entity or if it's the end of a spectrum of blepharospasm. As far as specific studies, no. I mean, I'm not aware of any specific study that's ever been published on apraxia of eyelid opening. As a general rule, it definitely is more refractory or more difficult to treat. Anecdotally, again, when we do treat this with injections, the only way to get any benefit is get right at the eyelash, what's called the pretarsal area. So when people that inject like this, it doesn't seem to work at all for apraxia of eyelid opening. But you do get some response if you do right at the eyelash, although it's, again, less robust typically and a shorter duration than you get with regular blepharospasm, I'd say.
Yeah, I think that was probably many, many years ago, Dr. Jankovic had studies that showed that pretarsal orbicularis was important to target in the treatments, correct?
I learned that from him.
What about diet and supplements? Do they have any impact?
Not that I'm aware. Nothing that I could find in the literature about it. Just coffee.
Just coffee. And here's one. One neurologist told me that some studies say that clonazepam causes dementia. Is this a common view in the medical community, or?
Well, yeah, clonazepam's it's a sleeping pill. Okay, so any sleeping pill is going to reduce your ability to concentrate. Now, to our knowledge with clonazepam, there's no long-term effect. So if you stop the medicine, it's not like it made you demented permanently. Mm-hmm. There actually is a little bit of evidence for that in anticholinergic medicines, that even if you stop the medicines, there's some potentially permanent worsening, which again makes them a little bit, a little worrisome to use, at least in certain populations. But certainly while you're on almost any muscle relaxant can slow you down and make you a little bit sedated.
Mm-hmm. And I mean, we use benzodiazepines for a lot of other conditions as well. I've never heard of it necessarily having permanent neurological effects. So, is there a correlation between dry eye, blepharospasm, blepharitis?
Yes. Yes, as I mentioned earlier, yes, almost half, 25 to 50% of the patients with blepharospasms has this symptoms of like dryness. Sometimes the slit lamp exam or the ophthalmological exam looks normal, but any condition that can cause dryness, such as blepharitis, like that means, for those who are not aware, is the dysfunction of the glands that produce oil on the lid margin, and that oil prevents the tears from evaporating. So if your tears don't last too long, in order to lubricate the eye, you have to blink. So there's an increased blinking. So there is a positive correlation. And again, in some reports and some study, the increased blinking and the dry eye symptoms precede the development of blepharospasms. However, not all the patients with dry eye develop blepharospasms. As an ophthalmologist, we like to treat dry eye first before going into medical treatment, like botulinum toxin injection, because if you're weakening the eyelid closure, then the eye may become more dry. So you want to make sure that the eye could be in the best state, whether with puntal plugs, helping clean and improve the quality of the glands. We'd like to use artificial tears. We'd like to do that first before initiating treatment for blepharospasm. But there is a positive correlation.
Here's a very direct question. So, Dr. Arando, what's your go-to medication?
Yeah.
I mean, you listed a lot of options there.
Botulinum toxin. I think the anticholinergic medicines overall probably have the best results, and then benzodiazepine second. Again, some of them are more just dangerous to use, like dopamine blocking drugs I almost never use because they do have some potential permanent side effects. Lithium I never use, same reason, there's other side effects with that. So mostly anticholinergics and benzodiazepines.
Dr. Guillet, you mentioned several criteria that you have for patients who are good candidates or necessary for DBS, but are there exclusion criteria? I mean, patients that come to show you, what sort of factors would give you pause in proceeding with that type of a procedure?
Yeah, so all the patients that we see get carefully screened, and that's why we depend on the neurologists and the psychiatrists to make sure that they have gone through and done all the testing to see that they are fit for surgery. So by the time they come and see me, there's usually no question unless there's like a cognitive problem. And I would say, age used to be one of those that you're like, okay, if they're over a certain age, you wouldn't offer them an operation. But now people are getting older and they live longer. So we have adjusted so that way age is no longer like a factor. And I think that the one of the contraindications would be whether to see if they would be able to tolerate, surgery, like if they have medical comorbidities, like end-stage renal disease or really bad heart disease, and they're on anticoagulation and they can't stop that. Cognitive dysfunction, so there's a risk for speech problems after having this. There's a risk for further cognitive decline after having brain surgery. So I think those are probably the more not direct contraindications, but more like you would be careful about pursuing surgery in these types of patients.
Is that a function of the surgery, the technical aspects of the surgery, or the anesthesia aspects of the surgery, or both?
I think it's a little bit of both, because anytime you undergo anesthesia, the elderly, they take a certain hit that I've seen in these Parkinsonian patients and essential tremor patients, more in the Parkinsonian patients. If they've already got some cognitive problems, then that's known to worsen after undergoing some anesthesia. The surgery itself, if you undergo bilateral thalamic surgery, for instance, you can have worsening speech or dysphagia after surgery. I think it's a combination of the surgery and the anesthesia.
Yeah, that's probably changing with time too, I would imagine, as techniques improve. And I always tell my patients, 90 is like the new 70.
Right.
I have so many patients now that I operate that are, over 100 years of age, whereas 15 years ago we would never even consider that. So the times change. I'm going to end with this last question, because I think this is an interesting one. I've never heard of this. Does eye color have an effect on blepharospasm?
No, there's no research on looking at the color and see if.
It's an interesting one.
So far,
is that a
there's
rumor?
no research, but
or is that a myth? Or I've never heard of that. So.
Have people stand up, whatever their eye color is.
Yeah. Or just raise their hands, I guess. How many blue-eyed individuals do we have here? So I'd say that's about a third. Brown? Maybe half. Green, hazel? It seems pretty good spread there. So, but that's a real interesting question.
I would say that maybe the pupillary size will have more effect, and it's like letting more light go in, photophobia, and that kind of thing. But I haven't heard either.
Well, I want to thank our panel of speakers here. Some really interesting talks. And so we have a break right now. Again, I apologize. We had a huge stack of questions here. We couldn't get through all the questions, but I'm sure if you wanted to grab one of the speakers afterwards and individually ask those questions, they'd be happy to answer them as well. Thank you again for participating in the symposium.